So my name is Eric Connor. I'm one of the co-founders of Healthify. Healthify was an idea that was born out of our experience working in clinics in East Baltimore. We saw doing community health work and patient advocacy that time and time again, patients, predominantly those members of the community who were most at risk, the food insecure, those who were substance dependent, those who were situationally homeless, those who were suffering from stress, depression, this whole range of needs that we term social and behavioral determinants of health, were often those who needed the most help, but often had, the clinic often had the fewest number of resources available to provide those individuals with care. I think Robert referenced very poignantly the binders full of information that we would have to access. You know, you'd come across a food voucher for Giant that expired 5 years ago, or there would be, a health, a food pantry at the bottom of the Baptist church that may or may not operate every third Tuesday. You really didn't know. And it was very difficult to connect patients with those services and coordinate their care. So Healthify initially began as a project to help Johns Hopkins Healthcare find and organize the services. And Johns Hopkins Healthcare ended up becoming one of our largest and first clients. And it really grew from there into a platform to help manage and coordinate care by connecting patients to community agencies. And we've really built it out from that starting point to find, not only additional services, but to assess patients for psychosocial needs, to track referrals, coordinate care, create a collaborative platform that diverse members of the community can work on. So today, Healthify works with a lot of Medicaid managed care organizations. We work with provider groups, and I think the time, those provider groups that serve at-risk members, and I think the time is really right now for these types of interventions. In New York State, they underwent DSRIP, a Medicaid payment reform, which created performing provider systems, which brought together not only healthcare providers, but community agencies as well, grouping them together in the same network to allow for coordinated referrals. And we have done a lot of work with a number of these PPSs, and I think a lot of states are eventually going to go down that route. I've had some conversations with some people in Pittsburgh about the potential of that idea moving into the future. I also think that with the Accountable Health Communities Grant, this is a wonderful opportunity that CMS, it sort of feels like, I don't know if anybody else got that feeling when reading through the model, that CMS had been sitting on this for a number of years, and it feels sort of like that senior term paper you never finished until the last month, and they're sort of just working to get it all together and get everything out before the current administration leaves office. That's what it sort of feels like, and I think that explained the originally very advanced application timeline in March, and I think they finally gave some people some breathing room. So remember, you all have a month left to apply if you're still interested in either track 1, 2, or 3. And I think it is really a wonderful opportunity to assist patients, align community services, and figure out what some of these needs are, assess patients in the community. And I think that's truly, truly wonderful. So what does, I got a little off track, and I want to talk a little more about the problem. I actually pulled this information for you for this presentation. And this is actually a breakdown of top searched needs in the state of Pennsylvania. Now, this is statewide, by community health workers and case managers. 67% of that chart is just food and housing. Now, when we look at a lot of the studies that have been done on social determinants and the varying degree of impact that they have on health, food and housing are two of the most basic and also some of the most costly needs. I mean, we can imagine food insecure diabetics whose SNAP benefits don't cover the entire month. We can imagine a whole variety of scenarios where these needs go unaddressed. And what does that result in? Medically unnecessary hospitalizations, more frequent hospitalizations, emergency room visits. It's no mistake that the AHC is asking you to look at emergency room visits and to stratify populations based off of that for the Accountable Health Communities Grant, because it is very telling. And I think you'll see that a lot of it ties back to unmet and unaddressed social needs. So with 67% of these searches being for those basic needs, that means that portion of the pie needs to get shrunk before you go into all the other ancillary stuff, whether it's legal aid or acute services for education, transportation, whatever it might be. There's a lot of work left to be done. And what does this result in? Well, some estimates give that about 1/5 of all Medicaid spending, that's around $85 billion a year, is directly affected by behavioral and social determinants of health. In some respects, it's not unsurprising. The United States spends more on healthcare than any other nation per capita, and we also spend less on social services than a lot of the other Western developed nations. So in a sense, we're sort of making up for it in our healthcare spending, but it's a very reactive solution versus a proactive one. So what we're trying to do is taking the cards that we have and giving this information to the hands of the healthcare system, who the case managers, social workers are very often the first responders. I mean, you are the first people that a patient who is in need goes to for help and for aid. People looking for housing, people looking for food, people saying, oh yeah, I'm in because of this, that, or the other reason. It's really, really important that this information be distributed widely to help address social and behavioral health determinants. And just to note that, if you were to look at Pennsylvania spends about $23 billion a year on Medicaid, so that's probably 5.5 to 6 billion potentially, of Pennsylvania's own money due to unaddressed needs, an increase in Medicaid spending. So what does Healthify do? As a platform, what we're focused on is giving case managers, patients, those who are in need of services or are looking to help other people in services, the ability to search for service in the community. You can type in food in Pittsburgh, and find out a variety of food pantries and other food-related resources. If you find a service that you want to refer a patient to, selecting on that service, tracking a referral, keeping all of this information aggregated in one place, then integrating it with the EHR, case management system, or if necessary. The ability to coordinate care directly, something that we've done in response to the Accountable Health Communities model, but also the performing provider systems emerging in New York State, was actually to give access to Healthify to both providers and community-based organizations. So that way you could securely send a referral over to a community agency. They would get a notification, go in, access the app, be able to say, hey, you have an incoming referral from Westchester Medical Center. Are you able to accept or reject it? If they accept it, person on Westchester will get a notification that that referral has been accepted. If it's been rejected, they'll get a notification that they don't have capacity to see this patient at time, and that'll prompt them to search for other services. And then, of course, with all the information being collected and for reporting for CMS, the ability to take that information collected, turn it into actionable reports, and determining, okay, this is what the needs are in my community. I have, X percentage of the population who they're HIV positive, but we don't have, Y number of services available to cater to HIV positive individuals. Let's see what we can do in order to realign the system. And I think that's the ultimate goal of track 3, at the very least, of the Accountable Health Communities Grant. So what I'm going to show you today is Healthify from a staff use case perspective. Here we go. And this is something that how do we get this back up on the? Sorry about this, folks. It's not an innovative tech demo if the innovative tech breaks the demonstration. I'm sorry, Robert. I'm making you work overtime. All right, look at that. So I'm doing that, you could make this patient-facing, you could make this, what we're going to do it is as if you were a case manager. So what I'm going to first start over here is on the resource sites search page. This is sort of the basis of the Healthify application upon which everything else is really built. So I'm going to do a basic search. So this was that main part of the pie over there, and I'm going to look here in Pittsburgh. You can tell I did my research. I previously typed in Pittsburgh. And what it'll do is it'll just pull up a list of food-related services within the geographic area of Pittsburgh. I mean, you could get really specific. You could specify McKees, you could specify Squirrel Hill, you could specify a zip code, a specific street address, and then you could narrow down and focus your search results based off of a radial search distance. I've set mine to a fairly high radial search distance, but a lot of people in New York City are maybe searching within just a couple of blocks because of the public transportation situation. But in areas where it's more reliant upon cars or other transportation, you can use other ways. And what we also went ahead and did is we've tagged each of these services with the other offerings on hand. So if is it a food pantry, do they do hot meals? Do they do food delivery? So that way you could filter down and find a specific service. And these are some of the different filter categories. Or if you're looking for food services, but you also want to see if there's an overlap with housing, you could filter for food-related services that have to deal with housing or with education or legal aid. If you wanted to send somebody to a one-stop shop, in essence, you could use Healthify to filter through different services. Let me do something maybe. How are we on time by any chance? Okay, now just do a quick search for HIV. So you could search on a disease-specific topic. So you could look at HIV, you could look at diabetes, and it'll just pull up and see what the overlap is. So if you're looking for housing services or food services that helped or cater to HIV-positive individuals, you could go ahead and do that. But let's take a look here at housing as another search example, and I'll go ahead and I'll click on one of these services. Yeah, I have to admit I'm a Mac user, so going back to Windows can be a little tricky to manipulate. But let's say we wanted to take a look at this service, see a little bit about what it did. We get information on when it was last updated. If you were actually using Healthify on a mobile device, whether it's an iPhone or a tablet, anything that is able to make a call, you could actually click on that link and you'd be able to call out directly to the service. So that's a clickable interactive link. Email address if you want to email somebody. Website if you want a little more information from its site. Hours of operation. An overview of the service. And this next steps section down here, this is what really benefits from if you were to add a community agency to Healthify. They're able to keep information up to date on capacity. Say if it's a food pantry, we serve 150 families typically a week. Or we typically, we're ADA compliant, we're wheelchair accessible. These are the items that you need to bring before coming in, whether it's an application or a referral form. So that's information that they can keep up to date on their end. And then, of course, the other resource program tags, eligibility tags, a quick little description. And then, we have some other luxury tools for community health workers, case managers, the ability to favorite resources. This was something that we got a lot of requests from social workers. They just wanted to have a little list of their favorite services. They'd have 10 or 12 services that they would frequently use, and they wanted to be able to pull that information up quickly. So we did, and we just went ahead and added favorites for them so that way they could easily access that information. And because we want it to be a collaborative tool, the ability to share and recommend services to your colleagues. So I can't tell you the number of times that I used to have a conversation with a colleague. I really wish I could find a service for I have a really anxious patient, I'm really trying to find a support group. I can't find anything. And then they say, actually I have just the thing for you. So we wanted to keep that element. So it's almost like a digital version of the old binder or the resource page that you'd put together or the Excel sheet, something that's easily aggregated and updated. And of course, making it printable. So clicking that icon would create a PDF printable version. And then this little button, the little edit button, we do a lot on our end to make sure resources in Healthify are accurate and up to date. To the best of our ability, we actually have a call center that calls and tries to verify as much of these services. We try to give as many of these accounts to community organizations as we can so they can keep and maintain their own information. It's something we've done really well in New York, but we're in 23 states. So you can imagine with 135,000 resource listings, that's pretty tough. So we allow community health workers, case managers, social workers to give recommendations on the services. Say, hey, you know, the hours of operation here might have changed. It might now be 9 to 6. You might want to call and verify that. So we just keep a note of all those changes, and we go through and we update them within 24 hours, so that way the resources are as accurate as they possibly can be. Because that was a big problem we identified in other resource databases, was they were very static. You would have information that was 2, 3, 4 years out of date, and if you're sending somebody over to an organization that no longer exists, you know, that breaks that bond of trust between a patient and their case manager. And you really, you know, or it complicates the relationship. And you don't want to waste a patient's time in any way, because if you think about being poor in America, it's a lot of waiting in line. It's a lot of waiting for benefits. It's a lot. It's just a lot. And we want to do our best to help facilitate that. Mitigate that. I'm sorry, that was a poor word choice. And then, of course, you know, private ratings and comments, again, at the bottom. You know, if you were to say, oh, Mary is the best person to speak to at this organization, or Peter is a great person to coordinate with. And these would just be private to any organization that's using the platform. And then here's the, whoop, I'm having those issues with the windows again. I really need to practice more. So let's say you wanted to send somebody over for safe housing, and then you could select a patient. And then I could talk a little bit about how you get patient information into Healthify. You could either use it standalone and add patients, or you could integrate it with an EHR or a case management system. But whenever you mention EHR integration, everybody on the provider side gets the willies, because it is, of course, a long and complicated process, but you know, it's definitely doable. And then when I send over that referral, I actually opted in for the patient to receive a text message. So I just received a text message from, you know, the organization making the referral, in this case Healthify. It says, hi Eric, you know, I want you to check out this service, and it gives some basic information for me to investigate. And then in the meantime, the patient record here in Healthify has been updated, and I'm gonna pull up, do a quick search for Eric here. Pull up my record, and you can see here that I am a high healthcare utilizer. It looks like I've been in every day this week for one thing or another. Definitely qualify as a frequent flyer. But you could see a list of previously made referrals, what some of those needs were, what, you know, is referred for referral for housing, food pantry, and then all the way down here, a list of previously taken assessments. Now, this is something else that we implemented because we got a lot of feedback from some of our initial deployments that there was just a lot of assessment survey fatigue on behalf of patients. They felt like they were getting asked a lot of questions, and they didn't necessarily always know why. So what we wanted to do was the ability to collect information on psychosocial domains, food insecurity, housing, but also recommend back to them a list of potentially useful services. So I'm going to go here and do a quick food needs assessment. And we have a lot of our partners who have just put in and customized their own existing assessments and just digitized them. And then what we've done is we have tied each of these assessment questions to those resource tags that you saw on the resource site search page. And what that allows for is whenever you complete an assessment on Healthify, it will give a list of recommended services, and it's just pulling from those questions how they were answered, whether a particular tag was activated or not. So it was just a convenient way to take existing assessments, existing things that are being done on behalf of patients, and then contextualizing it a little more, not only for the patient, but also a quick and easy way to collect information for a case manager. And you know, the way I'm doing it is typically a case manager would be calling telephonically or doing a sit down, but you could have these assessments as patient-facing in a kiosk in a waiting room, a kiosk in a waiting room, or sent out electronically through email. In person, the completion rate, or in a physical setting, the completion rate's around 95%. For digitally sent out ones, it's around 28%. That sounds really, really low until you consider patient portal utilization, which is around 1 or 2%. So if you're sending out an email or sending out a prompt through text or doing some way to get it in the hands of a patient, it's pretty good, and it's a great way to collect some information remotely. So you can see what we've done is we've taken that same information from the resource sites page. It's just pulling from my address in Jersey City. Don't hold it against me, Pennsylvania. I'm originally from New Jersey. So it's pulling off my address from Jersey City, recognizing that it's a food pantry, food service, and then I could have this print off and take it with me, or I just finish up the assessment and it'll update that profile. And the way we've designed Healthify is to sort of operate as its own miniature health information exchange. So if I were to then go into a CBO or another site or another clinic, it would pull that information from a previous referral or a previous visit and pre-populate the patient record. So that way the case manager, social worker, community health worker at the other site already has some clue as to my previous interactions. So it's just a convenient way to update patient information. Where are we on time so far, Robert? I feel like I've been talking. 10 minutes left. Okay, fantastic. And about 5 minutes for Q&A? Yeah. Okay. And then, so I'll skip over the analytics part. I've sort of showed y'all no, actually, we should have time. I'm just going to go ahead and do it. And y'all can start asking questions in a minute or two if you'd like. Oh, while I let that. I might have gotten greedy with signing. Okay, there we go. So just a quick example. So again, any information on Healthify we can contextualize and generate as a report, but you could use it to pull up quick insights into searching, for example, within the community. So you can see what the number of searches are that your staff's doing, what the breakdown of needs are. This is just pulled from our little demo account today, so this is what we've been looking at for the past few days. You can see what users are doing, number of resources, types of resources, and that type of information. Just a little additional contextualization for any administrator or any staff. Great. Any questions so far? Yes.
I don't mean the clinical results, but I mean, did they show up? How does one track the non-clinical results of those referrals? Do other agencies participate in that, or how is it done?
Yeah, absolutely. That's a great question. So if two agencies, so if a provider and a community agency are both using Healthify, and a patient goes into the agency that's also using Healthify, if they go in and interact with the system, or a case manager notifies the provider back, that'll update the provider that the referral was successful. But we've considered that even if organizations aren't using Healthify, we've implemented a few other tricks and tools. One of them being the ability to text patients directly about whether or not they went to a referral to get their feedback. Say, hi, did you go to this service and did you find it useful? And of course, if you're opting into texting, I mean, you've got to get the patient's consent to text or contact them or email them. But if they opt into that, you can do that. I mean, if they don't, and if another agency isn't using Healthify, it gets a little tricky. But you can also specify, and we have some other tools that will allow you to identify which services are on Healthify, which services are within your network, and we have a special label. It's just called a preferred provider, and that just means it's an organization that you've identified that your service works with. They're also on Healthify, and you can expect some sort of feedback from that interaction. Yes, sir. Oh, nope. Nope, the lady first. The lady first.
I have 3 questions. Is this on? Oh, so what's very frustrating a lot of times to both providers and consumers is that you go on a website and you find out a bunch of organizations that are supposed to meet your needs, but then you don't really have any information if they can serve you today. So let's say I need a shelter bed tonight. I go and I look, am I going to find out a list of places that have shelters, or am I going to find a place that's going to have that has a bed tonight?
Yeah, exactly. So that's why that next step section I was talking about is so critical when you're working directly with the community agency, because they can list their capacity. Let's say they have 8 out of 10 beds filled, and they could update that in real time to give you day by day. If not, it will be a static listing that just says they have, services, or they have the capacity. So that is a frustration, and that is a dichotomy.
You're assuming that the organization is going to go in and update as opposed to the...
Yeah, and we give them a little prompt to update their capacity every time a CBO like that logs in that has, let's say it's supportive housing or something, and they've got, maybe 15 beds. How many are filled tonight? Or if it's a shelter, what's your capacity? What are you currently at? Shelters are particularly tough because the lineup for them, and it's first come, first serve. So in a lot of places, I don't know necessarily here, so that it can be tricky regardless. I mean, particularly, and sometimes you'll get patients who don't want to go to a shelter for whatever reason. They don't want their stuff stolen. So it really, there are some very difficult cases. Yes, sir.
First of all, congratulations. A wonderful looking product.
Our engineers get all the credit. I'm not on the technical side.
You put them together, so good for you as well. Two-part question, really. We've been looking a lot at informal caregiving here in Pittsburgh.
Sure.
And I wonder if you might comment on how this might be morphed into something that would serve the average person, the informal caregiver. Yeah. And along with that, I was very curious about the ratings. And we have been lamenting the fact here that nobody actually provides any useful ratings about one service provider versus another. And how would you comment about yours being credible, reputable, useful, so on?
Sure. So the first question about caregivers, we actually did a caregiver project, and that was a main use of actually the assessment tool. It was to measure stress levels in caregivers, to identify what their needs were for those who are taking care of, whether it was a disabled family member or an elderly family member. So we've done some work on the assessment side and put in assessments around that place. And then, of course, we went through and made sure we added caregiver support services to help match with when we were doing that intervention. So it really, you could consider it in a sense as almost like a sandbox. We'll do a lot to populate and put in your general overview of services. But if you really want to run with it and specify and drill down into something, we have a team our community outreach team is staffed by social workers, all licensed social workers, and they'll work with you to get the right agencies in there and to set up sort of like a preferred network and identify those services. So, that's something that they'll do, bespoke in a sense. And then as for the rating system, so we actually chose to keep ratings private to organizations for the simple fact that it would be a confidential system that you would only be sharing with your peers. And we didn't want, so a service that you might find very useful, let's say it's a food pantry that only serves HIV positive individuals and you serve predominantly HIV positive individuals, you would find that a very useful service. But let's say you have no HIV positive individuals amongst your population, you're not going to be sending people to that service. So, a rating there, doesn't mean as much to you. So we wanted to be something collaborative amongst colleagues and something that they could know would stay private within their organization. So, sort of like a way for them to be honest amongst themselves.
Thanks for a great presentation. This is really an exciting kind of new initiative that you're presenting. I have a question, just, something that can be effective when you have a clinician that a patient will trust is that they can give a warm referral to someone else who they trust, and then through that relationship, that patient might be more likely to see that person because it's someone that they highly recommend. And so sometimes something that ends up being missing from technology interventions is that whole social component, and when all the communication is kind of more and more watered down. So I didn't know if you were thinking about adding a social media component so that you could do some of that relationship building online between providers who might not ever see each other's face.
Yeah, that's really interesting. So there is a performing provider system in New York that mentioned, well, it wasn't quite social media-esque, they did specify the ability to distinguish between different types of contacts at a service. They wanted one public-facing contact that they could list for the general public or any patient that they were making referral, but they also wanted the ability to list private contacts. Colleague, let's say they had a colleague or a coworker or somebody who was working at another agency that they wanted to coordinate directly with when making a referral or a handoff on behalf of the patient, somebody that they knew and trusted at the other agency. So that's something we're actively pursuing, the ability to toggle between an agency-wide referral and a very specific referral from one case manager at one organization to a colleague at another. The ability to do that handoff in a trusted environment like that. So that's a great point, and it is something that we have had brought up. Could you elaborate a little more on the social media aspect, though? I'd love to get your thoughts on that.
Oh.
Sorry to put you back on the spot. We can
Sorry.
talk after as well. Sorry, everybody.
I just mean if, for example, you had maybe like a leader of whatever agency and they have their own profile, and then you can have they can post statuses like, hey, we expanded our services, so now we have Sunday openings, everyone. And then someone can comment, wow, that's great, I love your services. So you get some of that kind of relationship building online that you might not get.
Okay, so almost like a forum or a space that social workers, community health workers could go to learn about new programs and share programs within the network? That would be a fantastic idea. I would absolutely love to speak with you more about that.
And the last question here.
Okay.
I'm kind of interested in the business aspect
Sure.
of what you're doing. One is I don't understand what the financial model is to sustain what you're doing. Number two, this is all kind of related. Who are your competitors in this space?
Wonderful question.
And if you have competitors, I have no...
Nobody can compete. It's just
I understand
we're
that.
too far ahead.
Are you creating a silo and your competitors are creating a silo? And do you have any plans to interface with your competitors?
Yeah, that's a lovely question. So to answer the first part, what's our business model? Typically, when we're working with a managed care organization, for example, we go with a per member per month, capitation, which is very straightforward. It makes a lot of sense to them. We're caring for the entire member population, trying to provide services for everybody in the network. If we're working with a provider, typically we'll look at some sort of user licensing agreement. Let's say they've got 150 staff members they'd like to put on, enterprise-wide. And we'll calculate, okay, what services, what are you trying to do? And we generally, cap costs for, access to the resource platform, to make it more amenable, because we recognize that if you're a safety net provider, things are tight. We work pretty closely. So user licensing for providers, per member per month for managed care. And it also works because they have different goals in alignment. As for our competitors, two come to mind. One is an organization called Aunt Bertha. They are a resource site, search site based out of Austin, Texas. We've met with their founder a couple of times. They're providing a lot of community services. I think they might actually have a nationwide database. We're only in 23 states. So I think they're a fantastic agency. I definitely recommend you check them out. The other one that I know of is out in Chicago called Purple Binder. They do something similar, but I think they've been focusing on government agencies and coordinating for public health departments to do a lot of this work. And we've actually actively talked with them about working together. Wonderful. Thank you all for your questions.